So, hello everyone, warm good evening on the finale of the program, the Second International E-Conclave for Oral Cancer. This day we are celebrating a wonderful theme, and we're going to talk about capacity building, how to dethrone that king of all the cancers in the country, the oral cancer, where we have the highest prevalence in the country because of various and multitude of reasons.
I now welcome Professor Dr. Anil DCruz. He is President of UICC for the term 2022 and Director Oncology Apollo Hospitals. He is ex-director at Tata Memorial Hospital, Mumbai. He is a researcher, administrator, and crusader in the field of cancer control with a special interest in tobacco advocacy. Dr. DeCruz has served on the UICC Board of Directors for 2 terms, adding value in the membership, governance, and finance committee. Dr. DeCruz served as editor of Manual on Clinical Oncology, a UICC publication, including numerous pivotal contributions in over 500 peer-reviewed publications. He is staunch supporter of ICanCare. I now invite Dr. DeCruz for his presentation on dethroning the king. Dr. DeCruz, please.
Yes. How do I do this? Okay. Am I seen? Am I heard?
Yes, sir.
Thank you. Thank you, Pavan, Shruti, your entire team for this opportunity to be yet again with you all on this lovely initiative from ICanCare. Dr. Agarwal, thank you very much for your kind words of introduction. Before the program started, we were just chit-chatting among the various faculty. And I did share with Pavan and Shruti that maybe we should have more time for discussion rather than me give a lengthy 30 minutes talk. But I would share some thoughts with you. I've tried to be brief and then probably set the stage for a good discussion that another dear friend of mine, Somesh, would lead. So I've been asked to speak on dethroning the king, the vision for India. I wear 2 hats. I wear a hat as an oncologist. I used to be at the Tata Memorial Hospital. I continue to treat, research, and teach head and neck cancer. And a large part of my work is oral cancer. I also am part of the UICC for the last more than 10 years. For those of you all who don't know, it's the largest NGO committed to the cause of cancer control, and it has members in 172 countries. So it truly is the voice of the civil society for cancer control. What I want to share with you all today is my vision both as an oncologist who's been treating this cancer for 30 years, as well as someone who's committed to the cause of cancer control. These figures are not new to this audience. Kostub did run through some of them. Oral cancer is a global problem, but we do have the dubious distinction of having the highest number in our parts of the world. Of the 350,000 new cases, of which half would die every year, more than half these cases are in our parts of the world, that is in Southeast Asia. What are the challenges that we have in treating this oral cancer? And that probably would help us on strategies onto how we could dethrone this king. There are a large number of cases, and these are paradoxically preventable. They come with late presentation. More than 80% are advanced. Therefore, they have a dismal 5-year survival. We can only cure between 20 to 50%, and that too with severe implications on function and cosmesis. There is poor tolerability and affordability to treatment, and truly it is a problem in our country. And I'm not sure whether the title given to this last session on dethroning the king, it may be the king, but it's probably not the right word, because it really is a true troublemaker and not a king, the oral cancer. There are 3 ways, and very simple, by which you can dethrone this king. One is prevent it. The second is early detect it, and Pawan showed some lovely photographs of people whose disease got reverted without him doing anything. So you need to detect them early. And for those unfortunate who get this cancer, we should cure them with correct treatment. That is the only way we would be able to dethrone the king. Prevent, early detect, and cure with correct treatment. Here is data about a year and a half back from our cancer registry program in the country. There is an increasing trend of cancer across all sites and in both sexes, but focus on the middle bullet. Common 5 leading sites are breast, lung, mouth, cervix, and tongue. So of the 5 leading sites in our country, 2 are within the oral cavity, just to tell you the magnitude of the problem. And why is this so? Because tobacco is a socially accepted custom in our country. We live with tobacco, and tobacco forms an integral part of our lifestyle among our countrymen. The photograph on the right upper corner is a little kiosk bang opposite the Tata Memorial Hospital, and it's sandwiched between 2 pharmaceutical shops, chemist shops, just to tell you how integral tobacco is in our country. And the photograph on the bottom right is a product that is available at one of these chemists, and that is creamy snuff, which is tobacco toothpaste that people use to brush their teeth with, in the belief that they're doing good, without knowing that the harmful effects could cause cancer. Here is global adult tobacco survey data. 266.8 million of our countrymen are current tobacco users, and a substantial number have been exposed to secondhand smoke. Look at this panel on the left side. 42.4%, that's more than a third, a little less than half of our countrymen 15 years and above use tobacco. Look at these 2 bar graphs to the right of this. You can see that while we do have a high prevalence of smokers, the prevalence of smokeless tobacco is much higher in our country. This is common even among children, adolescents. Between the age group of 13 and 15, about 20%, that's 1 in 5, would use tobacco. And the problem is also with secondhand smoke. Now, this is again continuation of the global adult tobacco survey. The mean age at initiation of tobacco is 18.7 years. That means if you are able to target people in schools and colleges, if they don't start till the age of 20, can someone be muted, please? Okay, so if you are able to stop people using before the age of 20, it's unlikely that they will take tobacco. Many of our people who use tobacco, they do want to quit. You can see smokers and smokeless is upwards of 30%, but the success rate is higher in smokers as opposed to smokeless, which is only 5.8%. So we need to control this tobacco menace. 42% of our countrymen use tobacco. They start before the age of 20, and the efforts to quit are more successful in smokers as opposed to smokeless, and smokeless causes a high incidence of oral cancers. So the message is very clear to you all that if you want to dethrone the king, target tobacco and target smokeless tobacco with equal fervor as opposed to smoked tobacco. Government does do a lot of work. We do have advertising is banned on the electronic media, but we see a lot of surrogate advertising, and we need to do something for that. We have heavy taxation on products, but predominantly on the cigarette. Most of our countrymen use the cheaper products of smokeless and the BD. Smoking is banned in public places, but I showed you the high percentage of people who are exposed to second-hand smoke in our country. So we don't enforce laws. Gutka and other products are banned in states, but as I speak to people who manufacture, they just tell me that ₹1 की पुड़िया 6 में बिकती है. That means the profit making is gone to someone else. We don't have legislation to see and enforce that it doesn't reach the end users. And we do have various organizations working towards the harmful effects of tobacco, education and cessation. Pavan and the ICanCare is one such example, but we need very many more people in this field to help in our fight against tobacco. I took the slide up again and again. It's an old slide. It's about a decade old. It's from the WHO bulletin looking at the policy in 41 countries that could avert smoking attributable deaths. This is predominantly for smoking, but it makes a very compulsory when you have various interventions that's protect air, offer cessation treatments, warning on packages, enforce marketing bans, and lastly raising taxes. The raising taxes has the best outcomes in stopping or decreasing tobacco use. Unfortunately, as I said in an earlier slide, most of our financial targets are towards cigarettes. So the finance minister each year will raise the price of cigarette taxes. Precious little is done for the low-end, cheaper products. And if we could target that, we would be able to decrease the consumption of BDs and the chewed products and probably decrease the incidence of oral cancer. Second, early detection and treating correctly. This is not unusual to us. 80% of our workload is like this. How can we tame the king with such advanced tumors? At 2 points in my career, I did a study as to why people come with advanced tumors. The average duration of symptoms was 7 months. 50% of time, the patients were themselves to blame, and sometimes it was because of socio-economic factors. But look, physician factors responsible to delay. Primary physicians was responsible in 50% of cases. The uninitiated treating a pre-malignant lesion, not understanding the implication. The uninitiated who are not head and neck cancer specialists treating a neck node with tuberculosis and missing and making the patient come with an N3 node. Of course, we do have people who go and treat non-medical personnel as well as alternate medicines in 16% of patients. So if we have to tame the king, we must have the physician factors as well as patient factors to improve. The financial status is linked to the growth and advancement and better living, which is government policy, and it will slowly improve. But we can make patients aware, and we can make physicians who are not taught head and neck to be aware of this disease. And what can be better than having data from your own country that good visual examination can save lives? The only trial looking at mortality as an endpoint in oral cancers. Nearly 100,000 patients in each arm randomized to health education plus visual examination of the oral cavity and health education alone. And you can see that mortality is decreased in those who use tobacco and alcohol. When they looked at the whole cohort, it probably did not have an effect. But when you look at the cohort, which are high risk users of tobacco and alcohol, you can save. So we can tame the king by having effective screening programs. This data was re-looked at a year or so back. And if we don't have the infrastructure to screen the whole country, we can do what is known as risk-based screening. If you screen about 2,000 individuals, you prevent one death. If you screen about 1,029 individuals, you prevent one death across the high risk group, that is tobacco and alcohol. And if you only screen 610 individuals, at the highest risk, that means those who consume a high proportion of tobacco and alcohol, you'll prevent one death. So if we don't have infrastructure to screen the entire country, which is logical, screen the very high risk people. Screen people in occupations that use it more. Screen people who frequent these shops to buy. They should be enrolled on programs. So the highest risk of individuals needs to be screened to prevent deaths. And we reviewed the literature on risk-based screening, and I wrote a nice Nature Reviews article. It's a prestigious journal. I wrote it with one of my faculty at Tata's, and it's just about a year or two old, that risk-based screening in oral cancers is ideal in resource-constrained settings, like our country, in high income settings when the incidence of cancer is not high. That's oral cancer for the foreigners, and also in times such as COVID, so that you don't have patients, everybody coming to the hospital for screening except the high risk individuals. We need to improve how we can deliver health care. Now, generally, we must horizontally grow, that is, strengthen our public health system. But efforts are only in vertical growth. New hospitals are coming up. For example, the hospital in which I work, the Tata Memorial, proudly says we have done 10 new hospitals in the country. But nothing is done for preventive. So if patients come in stage 4 in these 10 new hospitals, you'll still have a 20 to 50% 5-year survival. Something has to be done for the primary health of our patients. While primary health takes a long time to have its effect, a diagonal approach is important. But just making vertical growth, corporates, governments, new aims like hospital without strengthening primary health will not have the desired effect in taming the king. We can do this by a simple hub and spoke model where you have regional cancer centers that do high-end care. You have district cancer control programs, medical colleges and district hospitals that do the normal, not high-end work for oral cancers, and that's for all health. And you have the primary health centers that do awareness, screening, palliative work. They go out into the community. People with lesions come to them earlier. And only with this method will we be able to throne the king. We have a very different mortality to incidence ratio in our country, which is 0.69. That means for every 3 cancers diagnosed, 2 die. Compare it to cancers in the Western world, where out of every 3, only 1 die. And there are multiple factors that has this. If you look at Indian statistics, our mortality rate of cancers doubled in the last decade and a half. So we need to do something. It's also a cause of major financial burden. people have, they're just wiped out when they treat cancers. I just put a few figures up, but the out-of-pocket expenditure is 3 times higher for private inpatient care in India. Approximately 40% of cancer care costs are met through borrowing, sale of assets, contributions from friends and relatives. Look at this. The last bullet, these costs exceed 20% of the annual per capita household expenditure in 60% of Indian households. So the financial toxicity is a big problem and we have to do something for it. We can improve our outcomes by practicing evidence-based guidelines. Treat correctly. 50% of the patients that I treat are not treated correctly and they have redo. I just showed you the financial toxicity and now patients come for a second surgery. I did this study in 2013 when I was at Tata's with another fellow of mine, Dr. Mitali, who is now in Patna. If you look at guidelines, you will see that we looked at about 60% of patients who had treatment at the hospital and about 40% who had it elsewhere. The place of treatment was very significantly associated with adherence to guidelines. In working up patients, either place 90% of guidelines were adhered to. So everybody asked for a PET, for a CT, for an MR, for obvious reasons which all of you all can understand. But when it comes to the treatment, there were deviations, significant deviations in community compared to tertiary cancer care centers. So we must have some sort of legislation that people out in community treat patients correctly. All patients can't come to tertiary care cancer centers. We must strive for specialty practice. An old paper from Berkmeyer, New England Journal of Medicine, early 2000s it was published, looking at the outcomes of hospital volume, surgeon volume on operative modalities of 8 common cardiac and oncological procedures, basically advanced procedures. They didn't have head and neck in this, but I've just put it up to make a point. Nearly 500,000 patients. And specialty care was very, very important. The outcomes in a hospital, and please read this last line, that the effect of hospital volume is largely due to surgeon volume. So the point that Pavan is doing in this last session, capacity building, very, very important. Every Tom, Dick and Harry will treat oral cancers. A general ENT, a general oral maxillofacial surgeon without specialized training, and it compromises the success and the outcomes in our patients. So let anybody do it, but let them be trained well and let them have specialty practice. We must do research in our centers. Just treating has no use. Here I put another favorite slide of mine looking at the NHS outcomes in colorectal cancers. Over 200,000 patients treated in the UK. And you can see that centers that had a higher participation in clinical trials had a lower mortality, improved survival, and the longer they were in clinical trials, the better the outcome of their patients. And it's not only patients who are on the trial who benefit. Even patients who are not on trials, but if the doctors are tuned to the concept of research, do well. And that's called a bystander effect. These other patients are also benefit. They have improved and rationalized decision making. The institution practices evidence-based practice, and they're always exploring newer treatment regimes and instrumentations. And I proudly present research done by our group, which I led, published in the New England Journal of Medicine, one of the most prestigious journals, just telling us that if you treat the neck in the clinically node negative, you save lives. 1 death is prevented in every 8 patients treated with neck dissection, and 1 recurrence is prevented for every 4 patients treated with the elective neck dissection. This is the first trial from the Tatas that came into the New England Journal of Medicine. It's the first global surgical head and neck trial in the New England Journal of Medicine. And it's today the standard of care and guidelines across US, Europe, and even in our country. making a point that if you do research, it is possible in our country, and you improve the outcomes of your patients, plus you do public good by contributing and saving lives. Unfortunately, funding is poor in our country. Here again is Paul Gross's paper, then from the Lancet, showing the number of trials that are done. You can see our country is very, very low, and the number of cancer trials per 100,000 population probably is the lowest among most countries that do research, and we need to do something for that. If we don't have the money, I can understand public spend is less, and I've not put those figures up, but we can do cost-effective innovations of care. Metronomic chemotherapy, low-cost chemotherapy, but do it in a research mode. Do 6 fractions versus 5 fractions radiotherapy. Altered fractionation improves outcomes. If you treat people 6 days a week, you'll free up the machines faster, and you can increase the number of patients that are on the machine. You'll be able to save more lives. Maybe something exploratory like NACT, neoadjuvant chemotherapy. Give it, decrease the extent of surgery. And our N0 trial, simple trial, just randomizing patients into wide excision of an oral lesion with tongue versus no neck dissection, easily done. So I'm going to conclude sharing a few thoughts that cancer is a global problem. Oral cancer is India's problem, and we have a high explosion of cases. Although we had a national cancer control program since 70s, it's largely remained on paper. Much needs to be done, and we have to have a holistic approach focusing on prevention, screening, treatment, delivery, and equity to make this care affordable to all our countrymen. Then and only then we will be able to tame the tiger, the lion, or the king. Thank you once again, Pavan, Shruti, and the whole group for giving me this opportunity to share my thoughts. Thank you very, very much.
Thank you, Dr. DCruz, for the presentation. It was really a privilege to be the audience of this presentation made by you, a great person. Thank you, sir, for your presentation.
Thank you.
I think
I'll take it here then, sir. Thank you so much. So I think we had a great and what a terrific ideas presented by each of the 3 visionaries of the dais. I mean, lot of things to learn, lot of things to, as a takeaway message for our audiences, that and it's the most important 3 P's, that prevention is something which is done, the early diagnosis, and ensuring that right treatment procedure is followed, so that all these cases are tamed in the country properly. So ensuring that both the physicians as well as the patients comply and are educated so that they follow these principles and guidelines to ensure that the right treatment, the right diagnosis and screening is done on time, and so the advanced stages can be prevented, and ultimately this notorious king, the oral cancer, can be really stopped down in the country. But thank you so much. I would also thank Dr. Swatantra sir to chair the session, and I think it has been a great discussion so far.